everyone, Doc Allie here today to discuss type 2 diabetes in the African American community. Stay tuned. If you watched my previous videos, you know that I have a master's. I received my master's in health sciences with a concentration in public health. My goal throughout this program was to learn about the disparities that plague the African American community and try my best to find solutions to address and resolve them. So I decided, with the help of a good friend, to start a series on this channel that discusses these issues, discusses health promotion, health wellness, and also is a good video series for those that are going to be future healthcare professionals, that are currently healthcare professionals, to address your possible inherent bias and whatever else may be plaguing your ability to provide the optimal healthcare to those in the African American community. And this can possibly increase your cultural sensitivity, which will make you an amazing healthcare provider. So that's why you should tune in and stay tuned for all the future episodes that are going to be following. For those of you who don't know or who just need a quick refresher, type 2 diabetes is a chronic metabolic condition that affects the organ in our body known as the pancreas. The pancreas is responsible for producing this hormone known as insulin that helps move glucose from the blood into the cells. So you'll notice that these patients with type 2 diabetes have higher blood glucose level readings because their body is no longer responding to insulin. So the cells are no longer taking the glucose out of the bloodstream. As many as 29 million Americans currently have diabetes, and as much as 40% will soon be receiving the diagnosis. And if that's not startling enough, the African American community is noticing that younger generations are starting to get diagnosed with this condition by 2.3-fold more than any other ethnic community. There's so many beliefs as to why diabetes is plaguing the African American community like it is. The higher incidence of obesity, the physical inactivity, the insulin resistance, the genetic component. And then we don't really know what to do from there. But then you recognize that type 2 diabetes is actually the fourth leading cause of death within the African American community. And hopefully that sparks something in your guys' brain that says something has to be done. Something has to help with the prevention of this. Something has to help with the management of it so that we're not dying, or African Americans aren't dying from diabetes at such alarming rates. It's common knowledge that obesity is rising in America and physical inactivity is starting to become normalized. And so this is especially happening within the African American community. So the diagnostic age of 40 to 45 years old is starting to become younger and younger. So when you're making health interventions, it's never intelligent to say, eat healthy and work out. That's great. That's lovely advice. If only I knew what you meant by eat healthy and work out. So when you're saying eat healthy, what do you mean by that? When you're saying work out, where am I supposed to go? I can't afford a gym. My community's not safe enough for me to exercise in. So you have to take all these things into consideration when you're giving a health plan to a patient. You can't just expect them to know what eat healthy and exercise looks like. One thing that you'll notice throughout this series, and that I emphasized in almost every paper I wrote, was that I don't like to discuss the genetics of African Americans as a component for disease prevalence and health disparities, mainly because these are all theories. Nothing has been scientifically proven. So it's just an easy way to offset the responsibility of the health care provided to these patients. And so I read a paper that actually discussed this, and it said that it's easier for a provider to say that's your genetics, and it offsets their responsibility for how they provide for the patient if there's explicit or implicit racial bias. And so it doesn't mean that you're racist. It doesn't mean that you're prejudiced, but some people do have racial perceptions which can have a negative outcome on their patients. There's a pre-existing belief that African Americans with type 2 diabetes are not compliant with their medication regimen. So if a physician goes in with this assumption that their African American patient with a new diagnosis of diabetes is not going to adhere to any medication, diet regimen that they provide with them, they're not going to put the time or the energy into that plan with the patient. And that makes sense. If you really don't think that majority of your patients are actually going to listen to what you're saying, you're not going to put the energy in. Take out all the races, biases, all of that stuff. If you think that your patient's not listening to you, you're not going to put in the time or the energy. On the other hand, you have the patient. In the African American community, there's a great mistrust with healthcare providers. And that's a whole nother series. I'm gonna have to do a whole nother video that discusses the history behind that. But when you already have a physician who doesn't trust that the patient's gonna take their health seriously, and you have a patient who doesn't think that the physician has their best interest at heart, you're going to have this disconnect, and there's not going to be a good outcome from that. So if you guys don't know, I like to tie in a lot of psychology, and so this is basically known as the self-fulfilling prophecy. When you assume something, you manifest the idea, and then it ends up happening. But it didn't actually happen because of that's just what it was. It happened because you basically forced it into happening, if that makes any kinds of sense. Some reasoning behind poor glycemic control include the economic barriers to glucose testing, the literacy level within the pamphlets handed to these patients. All of these things should be under consideration. The best intervention I found was using the PEN3 model. The NIH funded a research project that used this model in their approach to diabetes within the African American community. The 3 in PEN3 stands for cultural empowerment, relationships and expectations, and cultural identity. By using this community approach, they were able to recognize that a lot of the African American community receives majority of their information from family and friends and not from professionals. They learned that there is more of a need for ideas behind food preparation and nutritional skills. They recognized that there were people who thought that this is why I hate the genetic component discussion of African Americans, because there are people who thought they were bound to have diabetes because it was in the family history. And then there were such passive communication within the medical office. There was such little late diagnosis, late recognition of symptoms, like the things that are commonly happening within the disparities of African American health, you're noticing even from this just one research paper. And so insurance coverage is another thing. Like, there's so much that happens, but people just blame the individual and say it's their fault that they're not taking their health seriously enough. So I'm going to cite this whole paper. I have it here as Kindred et al. 2010, and I'm going to cite that in the description. But the main thing to take away from this was they were able to create these toolkits that discuss these nutrition and dietary habits that they could do, finding ways for affordable testing and physical activity that was feasible and reasonable. And so this helped to ease the disparity within the community with that population that they were working with. Again, looking at the cultural aspect of African Americans, during this one study, I think this was the NIH study, in 2010, they found that 43% of those who responded to the survey said they would like to receive their information from the church. So my church, I just want you to know that it's coming soon. I'm going to start making sure that I provide the information that I can to you guys. But spirituality does play a role, and if you're able to incorporate that into the bettering and the health of the human body, treating it as God's temple and all of those things, you're able to work better and improve and encourage people to want to take those steps and to find the motivation when they already feel like, there's not much else they can do. Type 2 diabetes that is not properly managed can lead to lower leg amputations. It can lead to end-stage renal disease, diabetic nephropathy. The list goes on and on. Worst case scenario, death. And this happens a lot within the African American community. We've learned through the PEN3 model and the NIH research that culturally sensitive and culturally approaching interventions are more helpful in reducing the disparity, reducing the impact of diabetes on the African American community. So we just have to do that more. We have to try to find nutritional plans that are reasonable, that, there are meal plans out there. If there's ways for them to properly test their glucose levels regularly, that's affordable. Ways for them to afford their medications, make sure that their insurance covers it. The list goes on and on. But as you guys can see, I'm very passionate about this. That was one of my goals when I started my master's program, was to be the doctor that knows how to fix the problem that I'm seeing. And so I hope you guys liked it. Leave a comment, and until next time.